Welcome to ANX University. Today's session will provide you with a general overview of home health. We'll cover a brief background on the growing need for home health, gain a better understanding of the home health industry, and identify the eligibility requirements for home health. So why do we need home health? First, we needed to serve the growing senior population, to support aging in place, and finally to achieve the triple aim in healthcare. We'll go over each of these elements next. Consider this. 1 in 3 Americans is now 50 years or older, and each day 10,000 seniors turn 65. And by 2050, that will translate to 40 million additional Medicare-age patients flooding the healthcare system. This flood, also referred to as a silver tsunami, is driven partially by advances in medicine, but also by the aging baby boomer population. Because people are living longer, doctors will be dealing more regularly with the management of multiple chronic conditions. In fact, about 2/3 of all Medicare home health care users have 4 or more chronic conditions like diabetes or heart failure, and at least one functional impairment, such as difficulty walking. And as a population continues to age, the number of people with Alzheimer's diseases or other types of dementia will increase substantially. This means more seniors will become dependent on formal and informal caregivers. The number of people 85 years and older and who often require additional caregiving and support is now the fastest growing segment of the population, and by 2050, 1 in 5 Americans will be over 85. This growing senior population also intends to age in place. According to a study done by AARP, 87% of adults 65 and older want to stay in their current home and community as they age. Among people ages 50 to 64, 71% want to age in place. A recent poll commissioned by the EAR Foundation showed that seniors feared loss of independence and moving into a nursing home even more than death. This desire to stay at home and age in place has led to the growth of multi-generational households. Since 1980, the number of Americans living with multiple generations has been sharply rising. In 2016, according to Pew Research Center data, a record 64 million people, or 20% of the population, lived with multiple generations under one roof. The growth of multi-generational family living is growing among all racial groups, but Asians and Hispanic households lead the pack. Almost 1/3 of Asians and Hispanics live with multiple generations. And with aging parents in the household, many adult children are taking on the role of caregiver. AARP estimates that 34.2 million adults have served as caregivers in the last year alone. A vast majority of services provided in the home are provided by family caregivers, sometimes referred to as informal services. Upwards of 10 to 15 million individuals receive help from family caregivers, while 2 million hire professional caregivers to lend a hand. Watching our parents lose their health as they get older is one of the most challenging realities we must face. Failing health will mean greater dependence on others for things like bathing, dressing, and eating. Home health care can provide the necessary support for seniors who wish to remain safely at home. Another reason for the growth of home health is that it helps the health system achieve the triple aim. That means improving quality, both clinical quality and patient experience, improving the health of populations, and reducing the cost of healthcare. So how does home health do this? First, home health encourages greater patient compliance in treatment and more proactive care, which can improve care quality and increase patient satisfaction. Next, home health can bring diagnostics and treatments to patients, rather than passively waiting for them to go to a doctor's office or clinic, which is important to improving population health. Finally, home health can help contain costs through improved patient compliance, along with a reduction in emergency room visits and hospitalizations. In addition, the overall cost of home health is lower than that of inpatient facilities. Hospital stays can cost the healthcare system up to $41,000 per stay. Skilled nursing costs over $11,000, while home health costs just a quarter of that at $2,600.
Research has shown that 46% of hospital care can be safely moved to a patient's home, mainly for patients who suffer from chronic diseases. Technology serves as a key driver, with the advent of portable diagnostic devices in labs, advances in telehealth monitoring, and the growth of telemedicine, with doctor visits being conducted via video call.
Next, we'll talk about home health basics. We'll go over a discussion of home health, a brief history of home health, and finally, who pays for home health? Home health care refers to intermittent medically necessary skilled care ordered by a physician. It covers a wide range of healthcare services for acute, chronic, or rehabilitative conditions. Home health is one of the many healthcare delivery sites where patients can receive care, along with their primary care clinic, urgent care, hospital, skilled nursing facility, or other community-based services. The vertical axis indicates level of dependency, acuity, and cost. The higher the care delivery site is on the diagram, the greater the patient dependency and acuity, and the higher the cost. At the lowest level, patients can do self-care at home through virtual doctor visits or peer group counseling. If patients need additional help, the first stop is typically their primary care or specialty clinic. Care delivery sites on the left side of the diagram are what we refer to as pre-acute sites for care received before getting admitted to the hospital. And those to the right are post-acute care sites for care received after getting discharged from the hospital. As patients move up the acuity and dependency map, they may receive home health, go to urgent care, stay at a skilled nursing facility, or get admitted to the hospital. You'll notice that home health can be provided on both the pre-acute or post-acute settings. If patients require additional help after getting discharged from the hospital, post-acute care and treatment may be delivered in a long-term care hospital, skilled nursing facility, or in the comfort of their own home. There are also many community-based services such as social service organizations, adult senior centers, pharmacies, or other resources that provide support for patients. Up to 40% of patients discharged from hospitals go to some kind of post-acute care facility. Where the patient goes after being discharged from the hospital depends on 4 different criteria. First is the patient's choice and the treatment preferences. Do they have the support system and infrastructure in place to enjoy treatment at home? Do they have the ability and willingness for self-care? Second is the clinical need. What is their current health status? Are there any comorbidities? And what services will be covered by insurance? The third main factor is the facility or agency specialization and core competency. For example, rehab or wound care. Proximity to home is also important so that loved ones can easily visit. Next is the facility or agency's capacity. Are there enough beds or clinicians? The facility or agency's relationship to the hospital is also consideration. For example, are they a preferred provider? Finally, the provider's referral counts heavily. All things being equal, the case manager or discharge planner's referral often becomes the deciding factor. This is where reputation, marketing, and branding can influence the care delivery site. All of these factors influence where the patient goes after discharge from the hospital. There are various possible paths a patient can go through after discharge. 30% go to a skilled nursing facility, 32% go directly to home health, 5% end up at an inpatient rehab facility, while 6% continue care at an outpatient therapy clinic. Some patients who go to a SNF or rehab facility may go to a secondary post-acute care site, including home health. Bouncing around among these various care settings is very common. In the traditional care model, most patients go to skilled nursing care or assisted living facilities after hospital discharge. Community and home-based services are the smallest component of care. But in today's care model, the pyramid is getting inverted. With the senior population wanting to age in place, there's greater demand for home and community-based services. And thanks to advances in technology and enhanced services, patients can sometimes avoid going to the hospital first and instead receive care from other health providers, including home health. For example, a patient may start having difficulty breathing and is immediately plugged into home health services. With his care team's help, he gets better and never has to go to the hospital. Home health care is not new. Historically, most health care was provided in the home. Hospitals were places of last resort and were underutilized due to poor economic conditions. Only the wealthy could afford house calls from doctors. In 1813, the Ladies' Benevolent Society, a group of women volunteers in South Carolina, began the first efforts at providing home care services for those with lesser means. They quickly realized that trained nurses were required, and by the end of the 19th century, visiting nurses were hired to care for the sick at home. By 1890, there were 21 home care visiting nurses associations, and the need for home health care continued to grow. It became clear that people with chronic illnesses did not necessarily need to be hospitalized. In the early 1900s, rest homes were established for recovery and long-term care. And in 1965, Medicare was officially signed into law to provide healthcare insurance for older individuals. On July 1, 1966, the Medicare program, including Part A and B, was launched. In the original version of the program, patients could only receive home health after being discharged from hospitals or nursing homes. In 1980, Congress removes the requirement for prior hospital or nursing home stay to receive home health. Home health is now available in the pre-acute setting. The number of home health agencies explodes at this point. In 1987, as a result of a class action suit, CMS redefines the eligibility requirement from home health for part-time and intermittent to part-time or intermittent need for skilled care. With the change, home health became available to more beneficiaries for less acute conditions and for longer periods of time. A decade later, the Balanced Budget Act of 1997 radically transforms the Medicare home care benefit. The impact was swift. In the next 2 years, almost 4,000 agencies closed, and the number of visits per patient decreased, and public funding for home health was drastically reduced. Another home health milestone occurred in October 2000 when the case mix adjustment is introduced. Agencies now receive a fixed payment for each patient based on their acuity, determined using a tool called Outcomes and Assessment Information Set, or OASIS. This assessment tool helps measure a client's clinical severity, functional status, and service needs. In July 2015, the Quality of Patient Care Star Ratings are introduced on the Medicare Home Health Compare website. Consumers and health systems can now evaluate home health agencies based on their star rating, ranging from 1 to 5 stars. Today, there are 58 million people enrolled in Medicare, with an estimated 3.4 million receiving home health services. The increasing demand for in-home medical care has spurred rapid growth in the industry. Currently, there are 12,600 Medicare-certified home health agencies in the United States. In the Bay Area alone, there are 343 agencies covering San Francisco, San Mateo, and Santa Clara counties. Home health is a multi-billion-dollar industry funded largely by federal tax dollars. Most insurances pay for home health, but Medicare is the largest single payer, covering more than half of total spending. In 2016, total home health spending was $92 billion. It's projected to more than double and reach $225 billion by 2025. The full range of home health services include skilled nursing, skilled rehab, and custodial care. Medicare coverage of home health also includes medical supplies and durable medical equipment. Skilled nursing includes management of the nursing care plan, assessment of a patient's changing condition, and monitoring serious illnesses and unstable health status. Services include wound care for pressure sores or surgical wounds, injections, infusion therapy, along with management of medications, feeding or drainage tubes, and pain. Skilled rehab refers to the services provided by physical, occupational, speech, and respiratory therapists. Custodial care refers to non-medical care and is usually supplied by a home health aide or family member and includes help with activities of daily living like feeding, dressing, bathing, grooming, personal hygiene, and toileting. ANX Home Health Care specifically provides medical care at home, including skilled nursing, physical therapy, occupational therapy, speech therapy, and medical social workers. We also provide home health aides. The full range of ANX skilled nursing programs include advanced wound care, CHF management, pulmonary rehab, acute and chronic respiratory conditions, IV infusion, tube feeding, diabetes management, ostomy care, and palliative care. And our ANX skilled rehab programs include orthopedics, managing neurological conditions, and medically complex conditions. ANX also coordinates procurement of medical supplies and access to durable medical equipment, portable diagnostics, labs, IVs, tests, and other treatments. We also provide telehealth monitoring services for high-risk patients, which include remote monitoring of vital signs and virtual visits with a trained clinician. Out of all the care delivery providers, home health care clinicians are the only ones that enter a patient's home. Our clinicians are then able to leverage the home visit and get a more complete view of the patient's health and well-being. For example, they can check to see if there are home safety hazards like stairs or clutter. They can check to see if there's food in the refrigerator or family members present to help with care and companionship. With the repeated visits, our clinicians are also able to develop deeper relationships with the patients and have sensitive discussions about their end-of-life wishes in the comfort of the kitchen table or the living room. In this last section, we'll talk about who qualifies for home health, what conditions are typically treated with home health, and what services patients can expect at home. While anyone can request for home health services, certain conditions need to exist for the service to be covered by Medicare. First, you need to be confined to the home. Second, need intermittent skilled services. Number 3, be under the care of a physician. Number 4, receive services under a plan of care that's established and overseen by a physician. Finally, there must be a face-to-face encounter. A face-to-face encounter means a doctor must document that they've seen you within a specific time frame, 60 days prior or 30 days after being admitted to home health, and that visit was related to the reason that you need home health. Finally, one of the most important criteria is that you are homebound. Medicare considers a patient homebound if they need the help of another person or medical equipment such as crutches, a walker, or a wheelchair to leave home, or have a condition such that leaving home is medically contraindicated. A doctor decides if a patient is homebound based on their evaluation. After they start receiving home health, the doctor is also required to evaluate and recertify the plan of care every 60 days. The patient must also meet both standards in homebound criteria number 2. First, there must exist a normal inability to leave home, and leaving home must require a considerable and taxing effort. It is critical that one standard from criteria 1 and both standards from criteria 2 must be supported and documented for the patient to be deemed homebound. What does medically contraindicated mean? Well, this means that the patient may have an infection risk, their physician has specific precautions such as bed rest or limited activity, or the patient has psychological risks associated with leaving home, including fear and anxiety. Even if a patient is homebound, they can still leave home for medical treatment, religious services, or to attend a licensed adult care center without putting their homebound status at risk. Leaving home for short periods of time for special non-medical events like family reunions, funeral, or graduation is also allowed. They can even take occasional trips to the barber or beauty parlor without jeopardizing their homebound status. We cover the homebound status requirement in greater detail in another webinar, so be sure to check that out. So, what exactly defines a home? Well, it can be one of many different settings, from a private home to an assisted living facility to an apartment or a group home. According to Medicare guidelines, a patient's place of residence is wherever he or she makes his or her home. This can be their own home, a relative's home, or an assisted living facility. Under this definition, a patient can have more than one home. They may be able to get home health services at their primary residence, their vacation home, or a relative's home. Medicare rules do not prohibit a patient from having one or more places of residence. Excluded from this list are hospitals and skilled nursing facilities, as well as most nursing facilities under Medicaid. Facilities that provide diagnostic and therapy services for medical diagnosis, treatment, skilled nursing, or rehab services in other medical care do not qualify as a patient's home. So, who initiates home health? Typically, we will get referrals from hospitals, skilled nursing facilities, or physicians. Examples of conditions managed through home health include heart failure or other heart conditions, stroke, diabetes, COPD, Alzheimer's and other forms of dementia, cancer, amputation, joint replacement or surgery of the knee, hip, or shoulder, along with related issues from these conditions including wounds, falls, dizziness or loss of balance, difficulties with activities of daily living like eating, bathing, and toileting. In general, the goal of home health care is to help patients recover more quickly from illness or injury, regain independence, and become as self-sufficient as possible. Home health can also help maintain their current condition or level of function and slow decline. Some examples of what home health clinicians do during each visit include checking to see what patients are eating and drinking, tracking their blood pressure, temperature, heart rate, and breathing, monitoring the patients are taking their prescription and other drugs and treatments correctly, helping patients assess and manage their pain, checking their safety in the home, conducting home exercises, and teaching the patients about their care plan so that they can take care of themselves. Most importantly, coordinating care with the rest of the care team, including their doctor or health provider, case manager, family members, and any caregivers. Patients are discharged from home health if their doctor determines that they are no longer homebound, no longer require skilled medical care, or have achieved the care plan goals. How effective is home health? Well, in multiple studies, home health care after discharge from the hospital or skilled nursing facility has been shown to reduce hospital readmissions and lower healthcare costs. To summarize, home health's rapid growth is driven by a growing senior population, the increasing demand to age in place, the goal to achieve the triple aim of improving quality of care, improving population health, and reducing the cost of healthcare. With these drivers for change, home health is projected to reach $225 billion by 2025. Home health can be delivered in the pre-acute or post-acute setting and includes skilled nursing and rehab. And finally, the homebound requirement needs to be met for home health services to be covered by Medicare. We've reached the end of the session. For more information on home health, be sure to check out the resources provided on this page.